Hello, coders. Welcome to CPT Cardiovascular Surgery Part 3. I always like to try to make sure I break up my lectures into about an hour or less. So this one's probably going to be much shorter than the other ones, but I didn't want to put everything in a 3-hour lecture. So we're picking up with transcatheter procedures. This is on page 259 in your code book. So it tells us codes for catheter placement and the radiologic supervision and interpretation should also be reported in addition to the codes for the therapeutic aspect of the procedures. So this is just the therapy. They're telling us if we're using radiology, we're going to have to use another code. Now, it's first going to talk about mechanical thrombectomy. So this is when we're using a mechanism. So codes for catheter placement, diagnostic studies, and other percutaneous interventions like a transluminal balloon angioplasty or stent placement provided are separately reportable. So again, all we're doing is just doing the thrombectomy. However, these codes specifically include the intraprocedural fluoroscopic radiologic supervision interpretation service for guidance of the procedure. So they do use fluoroscopy. Okay, it goes on to tell us interprocedural injections of a thrombolytic agent is an included service and is not separately reportable in conjunction with a mechanical thrombectomy. However, subsequent or prior continuous infusion of a thrombolytic is not an included service and is separately reportable. So what they're saying is during the procedure, if we are doing both the mechanical thrombectomy to remove the thrombus that is in there, if we put in a substance during the surgery, it's included. If we do it after or before the surgery, then it's coded separately. But if it's done during the same surgical session, we only code the surgery. Now it tells us for the transcatheter thrombolytic infusions, codes 37211 and 37212 are used to report the initial day of transcatheter thrombolytic infusions, including follow-up of the arteriography, venography, catheter position change or exchange when performed. To report bilateral thrombolytic infusion through a separate access site, use modifier 50 in conjunction with 37211 and 37212. So again, what day is it? Is the initial day or is it the subsequent day? Okay, so it tells us we use 37213 to report the continued transcatheter thrombolytic infusions on subsequent days other than the initial day and final day of treatment. However, code 37214 is used to report the final day of transcatheter thrombolytic infusions. When initiation and completion of thrombolysis occurs on the same day, report only 37211 or 37212. So for these codes, we need to know how many days are they using this therapy for the patient. It tells us that codes for catheter placements, diagnostic studies, and percutaneous interventions may be separately reportable. But again, these codes include the fluoroscopic guidance and radiologic supervision and interpretation. Okay. Also, if the provider does a significantly and separately identifiable E&M service, they can code it in addition to these with modifier 25. Now again, ultrasound guidance is not included, so we may have to code it separately if used. And then for the intracranial artery mechanical thrombectomy, it's telling us exactly where we should go in the nervous system. So arterial mechanical thrombectomy may be performed as a primary transcatheter procedure with pre-treatment planning, performance of the procedure, and post-procedure evaluation focused on providing the service. Typically, the diagnosis of a thrombus has been made prior to the procedure, and a mechanical thrombectomy is planned pre-operatively. Okay, now, primary mechanical thrombectomy is reported per vascular family using 37184 for the initial vessel treated and 37185 for the second or all subsequent vessels within the same vascular family. So again, if we're doing an additional vascular family that's treated through a separate access site, we can use modifier 51. So again, remember, a lot of cardiovascular is about approach. How are we getting there, especially when we're dealing with vessels? Now, again, it tells us that the mechanical thrombectomy may precede or follow other percutaneous interventions. And again, most commonly, primary mechanical thrombectomy will precede another percutaneous intervention with a decision regarding the need for other services not made until after the mechanical thrombectomy has been performed. Occasionally, the performance of primary mechanical thrombectomy may be followed by another percutaneous intervention. So again, keep in mind, they're telling us right here, this code can be used by itself, but a lot of times it's used in conjunction with other codes. So we go in, we perform this procedure, we find the problem, and then we do another surgery on top of it to help fix the problem. Now, the biggest thing here, do not report 37184 and 37185 for mechanical thrombectomy performed for the retrieval of short segments of thrombus or embolus evident during other percutaneous interventions. See 37186 for these procedures. Why? Because 37186 is an add-on code. Remember, we have some of these very special add-on codes. You know, there's about one-ish in each major section of coding, and this is when done during another percutaneous vascular procedure. So again, we want to be careful with this. So again, we're always looking out for what's included, what's not included in these. So a venous mechanical thrombectomy uses 37187 to report the initial application of venous mechanical thrombectomy. To report bilateral venous mechanical thrombectomy performed through a separate access site, we use modifier 50 in conjunction with 37187. So again, separate access site, we use modifier 50. Again, for repeat treatment on a subsequent day during a course of thrombolytic therapy, use 37188. So again, time frames. How many days is the patient on this therapy? So, as we go through, we need to know exactly where we're going. Are we going into the heart? What part of the heart? If we're going into a vessel, which vessel, artery or vein? And then what specific vessel are we going into? And then what are we doing to that part of the body? So, you know, the biggest thing that we need to keep in mind is where are we? Because the cardiovascular system is all over the body. So we have to remember where specifically are we doing these procedures. Now, we've been talking about endovascular procedures, but we've mainly talked about the aorta and the iliac arteries. Okay, so now we're going a little bit further down the body. So 37220 to 37235 are used to describe lower extremity endovascular revascularization services performed for occlusive disease. So again, this is going to be usually for a fatty plaque buildup. These lower extremity codes are built on progressive hierarchies with more intensive services inclusive of less intensive services. The code inclusive of all the services provided for that vessel should be reported. Only one code from the family of 37220 to 37235 should be reported for each lower extremity vessel treated. So again, what they're telling us here is, again, these are hierarchical. So we're going from a basic procedure and we're getting more complex as we go up numerically. Now they tell us that the lower extremity endovascular revascularization codes all include the work of accessing and selective catheterization of the vessel, traversing the lesion, radiological supervision interpretation, directly related to the intervention performed in embolytic protection if used, okay? So again, we want to keep in mind, what are we coding for? So again, this is going down the leg, so we need to know what part of the vessels in the leg are we dealing with, okay? It tells us when treating multiple vessels within a territory, report each additional vessel using an add-on code as applicable. Select a base code that represents the most complex service using the following hierarchy of complexity in descending order, okay? So again, we go from arthrectomy and stent to just the arthrectomy to just the stent to angioplasty. So again, what are we doing? How extensive is this service? So again, now they're going to give us all the territories. So they're going to tell us. So again, the iliac vascular territory is 3 vessels: common iliac, internal iliac, external iliac. Femoral popliteal, so this is in the femur and around the knee. Again, it's one lower extremity. It's considered a single vessel. The tibial and perennial territory, again, is divided in 3 vessels: anterior tibial, posterior tibial, and peroneal arteries. So again, this is going down to the lower leg. Then again, we have things like the iliac vascular territory. Again, it tells us a single primary code is used for the initial iliac artery treated in each leg. If other iliac arteries are also treated in that leg, the interventions are reported with the appropriate add-on code. So again, we need to be careful how many of these vessels, because the initial code is only for one vessel and the add-on codes for each additional vessel. So for the femoral popliteal, it's a single interventional code is used no matter what combination of angioplasty, stent, or atherectomy is applied to all segments. This includes the deep and superficial femoral arteries as well as the popliteal arteries. And there are no add-on codes for additional vessels treated because, again, it's only considered one area. For the tibial and the peroneal, again, there's a single primary code, and then there are add-on codes for each additional vessel. Again, when we're treating multiple territories in the same leg, one prior lower extremity revascularization code is used for each territory treated. And then when second or third vessels are treated, again, we use the add-on codes for the additional service. But when more than one stent is placed in the same vessel, the code should be reported only once. That's important. They put two stents in the same vessel, we report only once. As soon as we start going into a different vessel, then we start needing another code. So the other thing to keep in mind is when multiple vessels and multiple territories in a single leg are treated in the same setting, the primary code for the treatment of the initial vessel and each vascular territory is reported. So again, where are we going? And then tells us the codes 37246, 7, 8, and 9 describe open or percutaneous transluminal balloon angioplasty. So again, this is going to be cutting into the body or going into a vessel. Code 37246 and 7 describe transluminal balloon angioplasties in an arterial system excluding the central nervous, coronary, pulmonary, and other lower extremities. So again, what is included in the code itself? Goes on to tell us that non-selective and or selective catheterizations is reported separately, okay? So these codes 36005 to 36248, these do not include a selective or non-selective catheterization. However, 37246, 7, 8, and 9 include radiological supervision interpretation directly related to the intervention. So again, it includes the radiological supervision and interpretation. And again, we can see here, it will say initial artery. So this is the base procedure, and then as we go up numerically, we go up in complexity, and then we have add-on codes for each additional. Okay? So it goes on to tell us that, and this is on page 266, the codes 37236 to 37239 are used to report endovascular revascularization for vessels other than lower extremity arteries for occlusiveness. So this is cervical, carotid, intracranial, intracoronary. So again, where are we? However, these codes describe a transluminal intravascular stent insertion in the artery. So again, what is included in a code description? Code 37236 to 37239 includes, again, the radiological supervision and interpretation directly related to the intervention performed, closure of the arteriotomy by pressure application of arterial closure device, or standard closure of the puncture by suture, and again, imaging performed to the document completion of the intervention. So again, what is included in these codes? Radiological supervision interpretation is included. And again, intravascular ultrasound may be reported separately. So if they use a small ultrasound probe, then again, it's reported separately. And again, we still see initial artery. That's why we have these add-on codes. So now we get to vascular embolism and occlusion. Now, codes 37241 to 37244 are used to describe vascular embolism and occlusion procedures excluding the natural service system of the head and neck, which are reported with those specific codes. and excluding the ablation and sclerotherapy procedures for venous insufficiency, telangiectasia of the extremities or skin, which are reported using 36468, 36470, and 36471. Embolization and occlusion procedures are performed for a wide variety of clinical indications and in a range of vascular territories. Arteries, veins, and lymphatics may all be the target of embolization. The embolization codes include all radiological supervision, interpretation, interprocedural guidance and road mapping, and imaging necessary to document completion of the procedure. They do not include the diagnostic angiography and all necessary catheter placements. So this is just taking care of the embolus itself in the body. So again, 37241 is for the endovascular embolism or occlusion procedures performed for venous conditions other than hemorrhage or hemodialysis. Code 37242 is again also for other than hemorrhage or tumor, such as an arteriovenous malformation or arteriovenous fistulas. 37243 is again used for the embolization for tissue ablation and organ infarction and ischemia. So again, what they're used for is also the separation. Code 37244 again is embolization of hemorrhage or vascular or lymphatic extravasation. So again, things like gastrointestinal bleeding and trauma and things like that. So again, where are we and what specifically are we doing? And in this case, why are we doing it? Okay, and then the next paragraph tells us intravascular stents, both covered and uncovered, are in a class of devices that may be used as part of an embolism procedure. So again, the biggest thing here is if we're using a stent, we need to know. Now, only one embolization code should be reported for each surgical field, so each area that we're going in, okay? And along with all this, a lot of times we've been seeing codes for the intravascular ultrasound, because when we go into these vessels, sometimes we want the ultrasound so we can get a picture of the inside out versus from the outside in. So we have separate codes just for intravascular ultrasound. These are very small probes that we stick inside of those catheters to go into vessels. So IVUS services include all transducer manipulation and reposition within the specific vessel being examined during a diagnostic procedure or before, during, or after a therapeutic intervention. So again, this can be used during a diagnostic to find out what's going on, or a therapeutic where we're fixing a problem. Now, IVUS is included in the work described by codes 37191, 192, 193, and 197, and should not be reported separately. Okay, so again, IVUS is included in those codes, so we can't code anything separate for it. And again, it says intravascular ultrasound, so we want to be careful. All right, guys, that is the end of cardiovascular. So I know that it took a long time, over 2 hours to get through it. There's a lot of information. Remember, when you're coding for cardiovascular, specifically, where are you? Are you in the heart? Are you in a vessel? If you're in a vessel, what type of vessel? And what's the name of the vessel? Okay, we need to know this information, and it should be in the surgical report. So always make sure that if it's not, to go back and query the provider and ask them what specific vessel they went in. Now again, this already should be in the system, but if it's not, that's when you always go back and make sure that you understand that they need to put in that information for you to code it correctly. All right, guys, good luck on cardiac coding.